Hello, and welcome to episode number 30 of the Johnversations Podcast. My guest today is a medical doctor who attended medical school at University of Colorado School of Medicine. He is currently a family medicine specialist in Waco, Texas, and is the creator of the blog Webb MD that was designed to address the massive amounts of falsehood, misinformation, and conspiracy theories related to COVID-19. Ladies and gentlemen listening at home, please give a very warm welcome to Dr. TJ Webb. Dr. Webb, thank you so much for being here. This is something I wanted to talk about for a while because everything that's out there has just driven me to the point of madness. So when I found you, I was like, I have to talk to this guy. I so hope he's willing to come on the show. So thank you so much for being here.
You're welcome. Thank you for reaching out. It's really a honor. This is the first podcast that I've ever been on, so I'm pretty excited about it. Also a little bit nervous, but I appreciate the invitation.
No, not a problem. And you know, it is really one of those things where like I reached out through your blog and then I was checking my email like every day. I was like, has it gotten back? Has it gotten back? Because I really want to talk to this guy. So when I got the email back, I was like, yes. I called my wife and I was like, guess what? So there was you agreeing to do this definitely is giving me a super sense of excitement. My house has been buzzing for the last couple of days. So again, just really glad that you're here.
Well, thank you, John. I appreciate that.
No, not a problem. So obviously, you know, as we mentioned in the intro, you run the blog Webb, TJWebMD.com, the best WebMD that's out there. So I most certainly want to talk about that. But before we kind of jump into the blog, I wanted to talk a little bit about you and kind of what led you to, you know, the path of medicine and being a doctor and helping others. You know, tell me a little bit about how you grew up, where you're from, things like that.
Sure, absolutely. So I was born and raised in a small town called Minden, Louisiana, which is, when I say Louisiana, people think, okay, Mardi Gras beads and, you know, boudin and crawfish etouffee and alligators. And while we have had all of those things, including an alligator in the pond next to the house I grew up in, you know, I grew up in the northwest part of the state. And so, you know, there are as many Cowboys fans as there were New Orleans Saint fans and that sort of thing. And so that's where I grew up, pretty small town, went to, was homeschooled through 8th grade and then attended public school for high school. And then went to a really small Southern Baptist college. We had, I think at the time that I was a student there, we had 900 or so students total. Which I know is smaller than a lot of people's high schools. But that's where I met my wife. And she was a year behind me in school. We always tell people we had chemistry together because that was the class that I met her in. So, and we got married right after she finished her nursing degree. And then, I think 12 or 13 days later, we moved up to Denver to start medical school. And she started working there as an RN in the oncology bone marrow transplant unit.
That's awesome.
So that's sort of brings us through. That's the first, 23 years of my life, I guess.
So what was it about? Because, you know, with medical school and deciding that, like, you know, hey, I'm going to be we have a friend who's a nurse practitioner here in
Sure.
Nashville. And I mean, just that, it's so many years of school and, you know, so many hours under your belt and stuff like that. So, you know, was there a certain time where you were like, this is what I wanted to do? Or do you feel like do you come from like a medical family or, you know, just kind of wonder if it's ingrained or if it's something that you found?
Sure. You know, I have an aunt who's a nurse practitioner. I think she was working on that degree while I was either in high school or college. It wasn't really on my radar growing up. I also have a cousin, one of her daughters is a surgeon, and she actually was the first doctor in the family. She finished medical school 1 year before I did, so she beat me by 1 year. It wasn't something that was on my radar growing up. You know, I wanted to go to school and do something that was going to make a lot of money. That's what I felt like I wanted to do. You know, as a high school student, as a 16 or 17-year-old, I was like, this makes sense. I'll make a lot of money and have a big house. That seems like the American dream. And so a few things happened my freshman year of college. Like I said, I was a Southern Baptist college. My wife and I are Christians. And you know, one of the things was I was really challenged by some friends at that university to start to take my personal faith seriously. It had been a very cultural thing for me growing up, even though our family, you know, were regular church attendants and devout in their religious beliefs. For me as a 17, 18-year-old, it was just sort of part of our heritage or tradition maybe. And so being challenged to kind of say, hey, this is what you say your belief system is. How does that actually impact what you're doing with your life, or your own personal decisions, or even the way you interact with other people? So that was one thing. The second thing was I started majoring in sociology. I had been sort of a pre-law major. I thought being a lawyer would be a good way to make money. And so I switched to sociology, and we watched a brief documentary on sort of the work that was being done with street children in Romania, and sort of helping them kind of carve out safe spaces in the midst of sort of these oppressive conditions and not really having any social safety network. And one of my friends after the video said, hey, I'd love to do something like that. And it was like this total paradigm shift. The idea that like someone I knew could actually devote their lives to helping others really was something that even at, 18 or 19 years old, I had never really considered, even though I had grown up on sort of, missionary stories and that sort of thing. And then the third thing that happened was during the summer in between my freshman and sophomore year of college, I really felt like sort of within my own personal faith journey, my own relationship with God, that I was being called to do some sort of full-time international work or international service. And I'll be the first to admit that there is a huge white savior complex that goes along with that. When I felt that calling as a 19-year-old, it was probably the same way most 19-year-olds feel that calling. It's like, oh, God wants me to go and save Africa, as though Africa were this monolith that needed saving. It was sort of this one place with one culture, and they needed the skills that I had, which at 19 years old, I think my skill set was I could ripstick and I could play Super Smash Brothers pretty well. And that was sort of the full breadth of my skills. But I really thought
that's a skill set. I mean, Smash Brothers is tough to get good at. So.
It is. And I think I was at that point, maybe the fifth best guy, in my dorm room. So, not to brag, but there's this arrogance that, that goes along with probably both religious and secular humanitarian work, where you really sort of think just because of the privileged background that I grew up with, that means that I'm entitled to sort of view myself as someone that has the skills and the abilities that people need around the world. And it just, at the time wasn't true. And even now, 16 years later as a physician, I still have lots of times where I wonder whether or not my skill sets are really necessary anywhere. So we've come a long ways in that, but that was certainly a big part of the calling to medicine as well. In terms of, I didn't want to, when I felt sort of God calling me to pursue missionary work or international work, I didn't want to go without some sort of skill set that was a perceived need. And at the time, I didn't think studying the law was going to be something that was needed internationally. Since then, I found out about organizations like International Justice Mission that, actually fights against modern day slavery and human trafficking, and then sticks around to sort of provide legal defense to make sure that people aren't re-victimized,
Right.
after they've been sort of set free and places like that. And it turns out we really, really need lawyers doing sort of humanitarian aid internationally. But I thought medicine just seemed really practical. I like science. I had always kind of grown up enjoying science, and I will say I was more of a Binkman's World science, nerd than Bill Nye the Science Guy science
nerd. I remember
nerd.
Binkman's World for sure.
Looking back, that was that show was kind of a mind trip. You watch that as an adult and you're like, what's going on there? But yeah, I mean, it seemed like a really practical direction to go. And it really wasn't until I was pretty far down that path that I really fell in love with the practice of medicine. So that was a long answer, but I've seen a few episodes of your show. It seems like that's okay.
It's totally fine. And I appreciate you being so open, because I think there, especially right now with just the general climate in the world, it probably takes a lot to say like, hey, I kind of recognize like this white savior mindset, or this,
Sure.
You know what I mean? Like, oh, like they need me there.
Right.
You know what I mean? Because it's got to be kind of a double-edged sword, because, it comes from a place of, I genuinely want to help people. But then after you get older and kind of get that in the hindsight, it was kind of like, oh, well, like they obviously just needed me there. So I can imagine it's kind of it's kind of a tearing back and forth as far as like, well, my intentions were good, but I've got to make sure that I like keep this in check and things like that. And it's funny because I grew up Southern Baptist as well. I'm not much of a religious person now, but I
Sure.
grew up, Southern Baptist, and my whole family was from Kentucky. They moved to Michigan and kind of brought that with them. So I had a lot of friends growing up that were like Catholic or like Protestant and stuff like that. And it's like, oh, well, you guys don't know how to like get down. Like, this is where like you sing and everybody's like throwing their hands up. And it's I think if you haven't lived a life in that religion, like you don't really, it's kind of hard to explain what it is compared to other ones, but.
Sure. Absolutely. And I think it's, there's all these sort of Christian subculture jokes that are sort of denominational, and maybe people who haven't been in that life sort of don't get, from the outside. I think you're right, John. I think it's really, we still struggle with, if we're invited to sort of do like, a short-term mission trip, which when you talk about how problematic and sort of perilous or at least laden with sort of possibilities to do harm, long-term missions is, sort of short-term missions sort of magnifies and multiplies that. It's really easy to sort of, the classic example is you bring like 20 college students and they sort of paint an orphanage and then they leave and they painted the orphanage badly. So it has to be repainted, but they were also sort of maybe, their trip was sort of messing up the local, painting economy. Local painters were sort of out of a job because they were going to do that anyway. So, and then the next month, another college group comes and repaints that same orphanage. And so there's lots and lots of opportunities to do harm with both short-term and long-term missions. And so we've had to really struggle with not only our white privilege, not only our cultural imperialism, and really questioning and kind of diving deep into, just in terms of introspection, trying to figure out what really are our motivations for kind of wanting to go and do international work. And then on the other side of that is, when you look at the state of healthcare in certain places around the world, and like I said, Africa, Southeast Asia, these places are extremely diverse in terms of cultural, historical backgrounds, political systems, degree of scientific, advancement, that sort of thing. And so you can't sort of say this continent or that country is sort of a monolith, but a lot of the places that still have incredible disparities in terms of healthcare, 10,000 people to one doctor as opposed to, one doctor for every 1,000 people in the United States. A lot of that is still the heritage of colonialism. And so it's really a hard place for me as a white male doctor who's trying to think deeply about those issues to go, so my solution to that is to come over there and offer more colonialism? Is that really is that the right decision?
Yeah, the airplane I flew in was called the Mayflower. That's right. Is that a coincidence? Yeah, Frontier Airlines, really, they have a funny naming system. So I don't think they even do international flights. So it's hard. It's, and you kind of go, on the one hand, there is a need, and on the other hand, there is so much opportunity to create mischief and create real harm by going with the mentality that my way is the right way, that by virtue of my education, but also just by virtue of my whiteness or my Western, culture, that I have all the right answers. And we see that over and over and over again in the history of, like I said, both religious and secular humanitarian, international humanitarian work. And so it's something we're still struggling with and working through and seeking out, guidance and wisdom and even correction from people who are in a position to be able to give that well. So we can go into more detail if you want to on that, but that's sort of where we're at. It's obviously we're still in Texas right now, but we still feel a call to go and to do some sort of international work long term. And our deep hope is we would do that in a way that protects the dignity and the culture of the people we're going to serve, and lets us to, kind of come alongside people in a posture of learning, while also being able to sort of give the gifts of the medical training that we both have, in a way that sort of really
tangibly helps the people that we serve.
Well, and it's cool that it's you and your wife. I think, that's gotta, especially if you're traveling all over the place, it's got to make it a little bit easier to have somebody there. And then again, to have someone that you can kind of work through those processes and just, kind of have those tough conversations. So you're not just in it alone. I did want to ask you this, like, how do you, because with having that, like, with identifying that complex and then saying, like, okay, if I'm going to go here, whether it's long term or short term, I have to make sure that I'm doing it in a way that is productive and we're not making things worse by being there. So, and I apologize because I definitely didn't mean to kind of go down this kind of hole, but I find it very interesting. Like, how is it that you and your wife are kind of able to balance those things, or what are some of the approaches that you take to make sure that when you're there, you're there in a healthy way, or in a way that's going to kind of produce the most good?
I think that's a great question. And again, I don't mind. I know this isn't sort of like a missionary podcast, but I certainly don't mind talking about it. I would say my wife, Katie, she's really she's advanced beyond me in a lot of these ways. I mean, she devotes a lot of time to reading and thinking and praying and discussing issues of race. And I try to too, but certainly I think she's sort of my senior in that. It's hard. I think the very first thing is that you assess felt needs. And so if there is a city or a hospital or a medical school or a village, which I know village is the number one stereotype, but you look at a movie like Black Panther and you kind of go, hey, there's so much good being done in a movie like Black Panther to reset our American cultural interpretation of what Africa is like. And I've traveled in Africa. I've been to huge cities, and I have been to small villages with a local well. And so I just, when we say village, we have to make sure that we're not kind of presenting that as all that there is in a beautiful, huge continent like Africa. I think when you go, you have to make sure that you're meeting felt needs, that if you're going as a doctor, you're going somewhere that has invited you and that has said, we really need a doctor that has sort of Western medical training that can do these types of medical services and that's willing to teach. And that's, the biggest thing to us is going and teaching in a role where you've been invited as a teacher. Because the way that you start to sort of make up for some of the historical harm through colonialism and to sort of right some of those wrongs and address some of those healthcare disparities isn't by kind of going and saying, well, I've got 30 years that I might spend here, and that's one extra doctor. And then when I get sick or when I die or when my kids, start going to college and I'm ready to retire, then we're back down to kind of square one. So the way that you do that is you go in a humble posture of learning, first of all, because there's so much to learn. You can't do medicine unless you froze, John. Are we still good?
We are still good. I'm still here with you.
Great. Very good. You're so handicapped if you, as a physician, if you don't have someone to help you navigate culture and language. And so you're already sort of going in this posture of, I've got more to learn than I probably have to offer, even as a doctor. But then ultimately you want to be able to teach. You want to teach medical residents. You want to teach nursing staff and other hospital staff. And what you want to do is bring the privilege of Western medical education that you've had access to, and then pass that along to people who are going to stay long after you and continue to pass that along. And obviously the very, very best people to do that are African doctors. Or if you're talking about going to, India, it's Indian doctors. Those are the best people to be able to teach because they understand the culture, they understand the language, they understand the value systems that are in place that have to be navigated. And the problem is that there just aren't enough. And so, our goal as missionary doctors is to be obsolete as soon as possible. The sooner, I've heard people in Africa say, we don't need more Western doctors. And that's a viewpoint that I think has to be really, really carefully considered and taken seriously. And the place that I've personally landed on that, looking at statistics, is to say, I think that might be true where you live. It might not be true everywhere. And the hope would be that it would be true everywhere really, really quickly, that people like me who are going to go and teach internationally, I'd love to just visit, because, I'd rather visit a country because it's beautiful and because the people there are amazing and hospitable. And I'd like to sort of go as a tourist and sort of contribute money to the local economy, as opposed to sort of going as someone who thinks that they have something to sort of, that they have something special to give. So I think it has to be done really humbly.
And I think you said a lot, you made a lot of great points, and I'll be honest with you, I never really, when I think about mission trips and going to these places to help, I kind of think of it exactly like you were talking before, where it's, a bunch of college kids, going down to Mexico to, help work on a school or paint a gym or something like that. But I've never really thought about it as, hey, as a doctor, like, I'm going there to teach. And it sounds kind of silly, but it's very much like you give a man a fish, he eats for that day. But if you teach a man to fish, they eat forever. And then they have that skill that they can pass on to, the next set of fishermen, or, you know what I mean? And kind of think, I guess I've just never processed it that way. So I'm sure, when it's done in that like healthy and respectful kind of way, it sounds like there's a lot of good coming, not just from you being there, but, if you are teaching someone and then they're teaching someone, like, you're leaving and you've created this mass, it's like dropping a stone in the river. It's just ripple, 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 ripple. But those ripples are going to end up hopefully saving lives the further that it goes out. So I think, that's, it's really cool. And it's really, really like commendable that you would dedicate such a large portion of your life. You help people all the time, but to then say like, hey, now I'm going to, get on this 14-hour flight or whatever and be here for months. I think it takes a special kind of person to be like, hey, I'm going to make that sacrifice to help others, and that's outside of like the whole, like the white savior, or the, like, I'm here to save people. But, it's still, it's a really commendable thing. You know what I mean?
Well, thank you. I appreciate that. I certainly grew up, and of course you grew up Southern Baptist too. So, certainly I grew up kind of, if you ever mentioned that you wanted to do something altruistic, especially if it was going to Africa or going to Mexico, or sort of going, oh, they need you so much over there, and that kind of thing. And then, so, like I said, I've kind of come full circle with that. And I hear the heart that you're sharing that with, and I appreciate that. But I think the part that I would add to it is, no matter what your level of education or expertise is, whether you're sort of the highest trained chemical engineer and you really do have some skill set that nobody else has that's needed in a specific, international location, if you don't go overseas with some degree of fear and concern that you might be doing more harm than good in terms of robbing people of their dignity, of going with sort of this cultural imperialist mindset. If you don't have that fear, then it's probably just because you haven't examined it enough. And so it's with great fear and trembling that we would sort of say, yes, we'll go internationally, sort of long term, to try to teach. And at the end of the day, what we kind of have realized from the short term trips that we have been on to sort of go to hospitals to relieve, the doctors that are there and that sort of thing, is most of it's for us. We come away getting so much more out of something like that than the people that we worked with got out of me being there. Even if we did save some lives, and even if we did teach some things, I've definitely learned more from the African doctors that I've worked with than I had to bring with me to teach them. And so you definitely go as a partnership, as opposed to going because you feel like you're gonna change the environment around you. You're also going to be changed by the environment around you, and I think for the better, because there's so much wisdom that we as Westerners, and especially me as a white man, has to learn from other cultures and these ancient and proud cultures that just people would just kind of go into and just kind of ignore and misunderstand and sort of brush aside, and there's so much that I have to learn. So
But I mean, again, not to like kind of dote on you too hard or anything like that. But I mean, I think it's,
Sure.
I think it's very, we're living in a time right now where it seems like people's opinions are pretty set in stone a lot of the cases, and they have like definitive, this is how I feel, and kind of tying it back to the blog that we'll talk about, like, you can find your set of quote unquote facts to back up any opinion that you have. So I think, going to these places and being willing to say like, listen, like I need to listen, I need to learn, like, and I've had that problem on the show before where it's been me and another white male guest, and we're like, well, hey, let's talk about this race thing that's going on. And then it's like, well, should we even like, are we the people to be talking about it? But like,
Sure.
like don't you want, like, but it's still good to have the conversation. So it's just, I mean, it's a crazy time, but I think at the core of it, like being willing to listen and being willing to learn is a whole lot more of what we need in this world right now than what we're getting. And so I think that's why it's so refreshing to hear that, like, hey, like if I'm going over, like I want to learn from these people. I want to bring stuff back with me. I want to have a dialogue or a relationship, and not just like white doctor man here to save, you know what I mean? So it's I don't know. It's cool. It's cool to talk to someone who has that mindset and who is so mindful about the impact that or that they could be making, good or bad. So
thank you.
I did want to ask you, so you graduate from University of Colorado Medical School, and then how did you land in Waco?
Yeah, that's a great question. I was going to just tack on to that
Sure.
last conversation. It's so funny that you, I've had so many of those experiences the last couple of years. We had this joke in medicine, or maybe some of us had this joke in medicine, that, hospital administration's answer to every problem is to add more hospital administrators. And so I'm sure it's the same thing. I mean, white men, our solution to any problems of race or gender is to just ask the opinion of more white men. So I'm glad that we're both kind of cognizant of that irony during this conversation. So how did we get to Waco? So there are family medicine residency programs all over the country. Texas has a lot of really, really good ones, but so does Colorado. During our fourth year of medical school, we had our first child. So a daughter, she's 8 years old now. And we knew that as much as we loved Denver, as much as we loved being close to the mountains and the city and going snowboarding and that sort of thing, we knew that we wanted to be closer to grandparents.
Mm-hmm.
Katie's grandparents are in Texas and mine are in Louisiana. And so we basically drew a big circle that was within driving distance from grandparents. And I think I interviewed at 10 or 11 programs within that circle and just a few that were outside of it. And ultimately, the family medicine program here in Waco was the one that felt like home. This was pre-Fixer Upper, or maybe in the early days of Fixer
I was going to
Upper.
say it's home of Chip and Joanna Gaines, which they've kind of turned the Waco reputation around, which is good. So
yes, yeah, there is this weird sort of moment in maybe 2012, 2013, somewhere where it was just like it switched from David Koresh and the Branch Davidians to Chip and Joanna Gaines. And I guess that's a really good change.
I mean, I guess.
Yeah. I'm not, Chip and JoJo won't watch this, but if they did, I don't want to draw a false equivalence between them. They're great. So I think so. It's a really good change for the reputation of Waco. Obviously, as a city, we are dealing with the heavy issues of gentrification and increasing tax brackets and that kind of thing that come from a city sort of growing economically. And I think city leadership and everyone involved is really trying to figure out the best way to do that well. That still sort of protects the dignity and the livelihood of people who have called Waco their home for decades and decades, with all these young professionals moving in. But we ended up in Waco. It felt like home. Did our family medicine residency training there, 3 years, very intense, full spectrum training, learning how to do C-sections and high risk obstetrics and gynecology. Of course, working in the hospital, working in clinic, working emergency department shifts, and really trying to train in such a way that if I was the only doctor in a town or in a village, right, I'd be able to take care of almost everything that came in. And that's kind of the mentality for a lot of the training programs in family medicine and especially in Texas. And then we loved Waco. We didn't feel like our time was up there yet when I graduated, so we decided to stay.
That's awesome. Yeah, and it's I mean, I think it kind of harkens back a little bit to the way that you're describing it is like kind of like the small, because Texas, even though you've got like Austin and Dallas and all these big cities, it's still it's a incredibly large state with tons of like small towns. So it kind of harkens back to like the old, like, oh yeah, it's the town doctor, and he can whether you need a tooth pulled or a C-section or whatever, like he can do it all. Which is, I think that makes you, at least for me personally speaking, like I feel like I trust my doctor a little bit more because of the fact that I'm like, oh, I don't have to go to 14 different people. Like I can go see him for this or her for this to, I think it instills a bigger sense of confidence in that person. And then from that confidence, you have the relationship grows and things like that. And from what I understand, like you've worked really hard on building the relationship with the community. I know something that you do is, try to help people kind of navigate through the healthcare system, because my wife did utilization review. So, she's working with insurance companies, and, it can be, even for someone who did that for a living, it can be a nightmare to go in and do it, 8 to 5 every day. And then you don't know anything about it. And you're like, well, I'm trying to call it, because, insurance companies typically aren't trying to fight for what's right for you. And
say that louder for the people in the back. Yeah.
Right. So, talk to me a little bit about you, because again, I definitely want to get to the blog, but I kind of wanted to make people aware of like who you are and where you come from and what you're passionate about, so that it translates into that when we get to it. But talk to me a little bit about why that's so important to you, to make sure that people have those tools and what they need.
Yeah, absolutely. And I think I certainly see at some point in my future sort of maybe being that only doctor in town type thing, or if not only doctor, because that sounds really, really exhausting, then being able to offer as many services as possible, sort of without having to send somebody 2 hours down the interstate to a larger city. In Waco, we're blessed to have really amazing specialists and good hospitals, and so we don't have to do that because of geographic realities. But the clinic that I work at, Waco Family Health Center, is specifically designed to kind of bring healthcare equity to the entire city. And so I think we have like 13 or 14 different clinic sites. They are strategically located kind of throughout town in such a way that they're accessible by bus. They can be walked to from some of the areas of town where people are statistically less likely to have access to a vehicle, or have access to a redundant vehicle to go to a doctor's appointment while another family member is at work. And so health care equity is a big part of what our focus is as a clinic, and obviously to us as individuals as well. And so that means that I have patients who they have the Gold Star insurance through Aetna or Blue Cross Blue Shield. I've got patients on Medicaid and Medicare, and I've also got patients who are literally paying with cash for their healthcare services, or they're on a sort of internal sort of county, state, and federal funded co-insurance program that helps cover things that are done in-house, but doesn't really give them access to more specialists and specialty services. And so even though we have specialists in town, actually a lot of our specialists are great. They volunteer their time to come see our patients, and don't sort of, they don't get compensated for that. They just believe in the mission of the organization. But it means that I spend a lot of time being the cardiologist or being the rheumatologist for patients who just don't have access to those services in the outpatient setting. And so that jack of all trades training through family medicine is really well suited to that type of work. But it's really hard. I mean, it means that I spend a lot of time sort of looking at websites that have coupons, for prescriptions, going, well, if we did this dose and we did 15 of them, then it's this much at HEB, which is our local, grocery store chain. And if you do this dose and you do 30 of them, that'll get you through the month as well. And that'll be this many dollars if you drive over to the Walmart pharmacy. Oh, you have a Sam's Club membership, then we can look at their generic program. And so you spend a lot of time both advocating for your patients, but also trying to help them learn how to navigate the system. And really, when you're talking about people who don't have private insurance and don't have a large amount of sort of economic resources, then you're trying to help them navigate a system that, you could easily say wasn't built for them, but you could also, it wouldn't be a stretch to say was specifically built to exclude them when you talk about sort of American healthcare in general.
Yeah, I mean, I would venture to even, exclude definitely, and I would almost venture to even say extort on some cases. Like, I was 20, no, I must have been like, no, I must have been right about 2021. I grew up playing in bands and stuff like that. And I was recording vocals for a song, just singing. And I started feeling like I was getting stabbed in the side with a hot knife, and I dropped to the floor. And I'm like not a small guy, but I couldn't muster the strength to stand up, and I didn't have insurance. It was before Obama had passed you can stay on your family's insurance until you're 26. So
sure.
My friends didn't know what to do. So they took me to the emergency room and they charged me like $2,000 for an IV and an X-ray. And I'm working at Subway and then living in a van,
down by the river.
Well, we were just touring. So a lot of nights down by a river because we didn't have anywhere else. But it's, I'd work at Subway for a couple weeks and then get in the van and we go play, a handful of shows and then come home. So they were like, yep, we don't see anything wrong. So that went on for probably 7 months where it was just like that pain. And then wow. I got insurance, and I went into a doctor, and they're like, it's your gallbladder. They were like, and we want to remove it tomorrow. Because I had insurance, they were like, hey, like, let's figure out what's going on. And,
right.
And I was paying that off until I was, an adult, well into like my like real adult years, you know what I mean? And so it's just like, and let me ask you this. What do you think about the fact that, I could come into your hospital and this procedure may cost this amount of money, but then I could go to another hospital, 15 minutes down the road, and it's, $300 more expensive or $200 less. Like, as a physician, what are your thoughts on that? Because again, it seems like you are definitely from our conversation so far, I get the sense of you that you're very much for the people. So, as a physician, what are your thoughts and feelings behind that? Because I'm as someone who's not, I know it can be maddening to be like, what, like, how is it so much more expensive here than if I were to go here?
Yeah, absolutely. I think the whole system's kind of crazy. It really is. And I would just say I've known, I want to write a post for the blog eventually, and I think I'm going to title it "I Know More Bad Doctors Than You Do." I've known thousands of doctors, and I could probably count on 2 or 3 hands the number of doctors that I wouldn't let care for my family member. And I could probably count on one hand the number of doctors that I really thought were just in it for the money, were sort of not altruistic in their aims, didn't really care about their patients. It's just so rare. It happens, certainly. Doctor death and that kind of thing.
Right.
And there are doctors that are negligent, and there are doctors that are suffering from addiction issues and things like that. We are not this paragon that's sort of set aside from the rest of society. We have the struggles anybody else has. But for the most part, almost all of the physicians and nurses that I've worked with over the years, medical school, residency, not private practice, but practice afterwards, were in it for the right reasons and really cared about people. But so much of that, that realm of money is detached from what we do, and so I bet the surgeon who did your gallbladder didn't know how much money it was going to cost you. I certainly don't. I couldn't put in an exact dollar figure on how much it costs to come and see me in the office. And I get that question all the time. And certainly my job is to help figure out how to get it done in sort of the cheapest way possible. I usually, my patients believe that if they have a medicine at the pharmacy that is going to cost them $300 that I'm getting like $150 of that. And the truth is I don't get it. I don't get any of that money. But I don't want to prescribe a medicine that's going to cost $300 for a patient who can't afford it, because it's not going to be effective because they can't buy it. And so I usually in my visits by kind of telling the patient, I say, okay, John, these are the medicines I prescribed you. I think this one's going to be on the $5 plan. Here's a coupon for this other one. This one should be covered. But if you get to the pharmacy and it's an insane number, they want $50, they want $100 for this medicine, just call us in the morning and let's find an alternative. And so a lot of the exploitation that happens financially is because the system is so messed up, so seemingly random, and the allies of patients, which are doctors and nurses, just aren't maybe that much better at knowing how much things are going to cost than the patients themselves are, because the system is so chaotic and so random. And I'm not a healthcare policy guy at all, but I see so many benefits to taking out of that equation of how healthcare dollars are spent, taking out of the equation people who are really getting rich from it, and saying like, hey, if your whole job is to siphon money away from patient care, and I'm not pointing fingers or naming names, but if you've bought a yacht from denying claims this year, then you're probably part of the problem and not part of the solution.
Yeah,
and
or off the cost of EpiPens going up to $500 if that built the addition where your indoor pool and basketball court is, like,
yeah,
I've got a problem with that. So.
Absolutely. So I think there does need to be some careful regulation, and I think a lot of that regulation needs to be focused on making sure that patients who don't have the same access that someone with good private insurance and money in their savings account has, make sure that they're not sort of the unintended, kind of casualties who are caught in the crossfire of this arms race between hospitals and pharmaceutical companies and insurance companies. Sort of, we're going to pay this. Okay, well then we're going to charge this. Okay, then we'll pay this. And it's the people who are, driving around with their friends in a van from state to state, kind of living their life, but don't have insurance, who then find themselves having their health impacted by that. And so that's the battle that we fight every single day, in my clinic, is trying to help people who have been kind of lost by the system navigate that. And I think maybe it's not the doctors specifically who are driving that, but there probably is more that we can do. There's probably more that I can do to advocate on a larger scale in terms of system-wide changes as well.
Well, let me ask you this. I mean, how do you think that, because I can imagine if I came to you as a patient and I saw that you were like, hey, listen, this medicine is going to be, super expensive. So I've taken the time to go through, like you said, here's this coupon, here's this, if it's too expensive. How do you think that strengthens the bond between like your practice and the community? Do you see a lot of, I would imagine that people put a lot of trust in you because of the fact that it seems very evident that you go the extra mile to kind of make sure that you're not putting people out, especially people who may be, in that kind of like low income, high risk kind of situation.
Yeah. I think, I hope so. I certainly hope so. There's good word of mouth and there's bad word of mouth. And I do think that a place like Family Health Center where I work has a degree of trust that has been built in the community over the past 50 years. But I think that it's an uphill battle because so many people, either because of personal stories or shared cultural narratives, some of which are not true, but many of which are true. So I have to burp.
Go for it. Let it rip.
Can we edit that part out? We'll edit the burp out of the podcast.
You muted. We're good. So don't even worry about it.
I think when you look at the lack of trust in healthcare, even this sort of persistent myth that, the doctor is looking at the wallet biopsy, the doctor is really trying to figure out how to get the most money out of you and things like this. There's truth historically in that, and especially if you are a marginalized group, especially if you are African American, if you are female, if you speak a different language or come from a different, cultural heritage or a different country. modern medicine and American medicine does not have a spotless track record in terms of not only negligence, but also abuse. And so, and it doesn't always get recorded in the literature the way that it should, although there's some changes in that. I'm reading a book right now called Medical Apartheid by Harriet Washington, and it's a historical survey of medical experimentation on Black people in America from the days of chattel slavery all the way through the 1990s. And so, growing up and sort of reading about medical history, we might think, oh, the Tuskegee syphilis experiment and maybe some bad things that happened during slavery. And that's kind of the two times that medicine was abusive towards Black
Tuskegee
people.
Tuskegee was the first thing that came into my head. I was like, oh, that's freaking awful.
Yeah, absolutely. And just for those that don't know, you can look it up, but it's an experiment that ran from the 1930s to the 1970s in Macon County, Georgia, I think. Basically, the whatever the U.S. Public Health Department, I forget what the actual name of the department was at the time, did an experiment where they had all these Black men who had been diagnosed with syphilis. They were enrolled in this experiment that was advertised to them as being curative. They were going to be treated for syphilis. And really the intention was to not treat them for syphilis and to follow the natural course of the illness. And so a lot of the information that we have about, primary and secondary and tertiary syphilis, neurosyphilis, the way that syphilis then creates these long-lasting, neurocognitive disorders and eventually can cause death. This comes from the study that was done. And at the time that these people were enrolled in the study, sorry for the history lesson. At the time that the people were...
No, please. Because I think it's something that like people, especially right now, like if you don't know about it, this is something that's really worth knowing about.
Sure, absolutely. And Miss Washington in her book, Medical Apartheid, she writes about so eloquently and so well. She's a historian who loves science, who loves medicine, and she's just able to very incisively write about these issues. But basically they were enrolled, and even though there were some gold standard treatments at the time that weren't very effective, they weren't given those treatments, even though that would have been offered to sort of private pay patients or white patients. But then the really alarming part of it, if that's not bad enough, is that when penicillin was discovered and then was found to be curative for syphilis, like you can take penicillin, and if it's given in the right doses, depending on the stage of illness, then you are cured from syphilis forever. They decided to continue the study. They decided to continue withholding treatment, even though a cure had been found for this disease. And the excuse that was given by higher ups in government was, well, now that we have a cure for syphilis, we expect it to become rare. And so this is our last opportunity to see the horrible physical ramifications that come from this disease. And so when you read the book, she talks about how they worked so hard to prevent people from being lost to follow-up in this experiment. People kind of knew, they kind of got wise to the fact that they weren't being given the treatments that other people were given. And they would sort of drive out of the state or drive to a different city and go and seek treatment. But a list of their names of the participants in the study had been faxed ahead or mailed ahead to different government treatment facilities. So they were actually denied treatment because they were part of the study. And so then they go to a different place and kind of give a different name and present with maybe like a relative's ID, and they would get treated. And then the people running the experiment would go, oh no, we lost somebody because they managed to get penicillin. So it's so... It's so horrifying as a physician to hear about doctors being involved in this. But that is the history that we have to own up to when we are trying to address healthcare disparities. And when we say kind of, oh, how come sometimes my Black patients don't trust me as a white doctor? It's not because they're suspicious of me. It's not because they have a hard time, but all these sort of myths that we have that we tell ourselves about iatrophobia, Black people are just afraid of medical treatment, and these sort of myths that have been perpetuated within healthcare. It's because there's a shared historical narrative in certain cultures and certain demographics about the real abuses that have occurred over the years that you have to be careful about. And the point that Miss Washington makes in her book is, when we think about the Tuskegee experiment, which is something that's kind of common knowledge, people sort of know the basics of this. Number one, the Tuskegee experiment is way worse than even I thought it was until I read her book. I mean, you sort of know a little bit about it, and then you kind of realize how deep the depravity and abuse and exploitation goes. But number two, it is a link in the chain of the way that medicine has failed African American communities over the years. And so when I'm talking to, specifically if I'm talking to a Black patient, and I'm working on building that trusting interpersonal relationship like I try to do with all my patients, and I'm really getting the sense that I'm not being trusted. Obviously I have to ask myself, have I behaved in a way, or have I said something that comes off as untrustworthy? Obviously that's the first question. But a few years ago, I would have probably said, hey, it looks like you don't, John, I'm going to keep using you. John, it looks like you don't trust me right now. It looks like you're really suspicious of me. What's going on with that? And now with a little bit more of that historical framework that I've had to kind of confront and sort of be really honest with myself about as a physician, it's a lot easier to sort of go, hey, is it, I had a patient the other day who I sort of got that vibe from, like, hey, I'm saying, hey, here's the treatment plan. Here's what we're going to do going forward. Here's what I think is best. And I'm just kind of getting that standoffishness of I don't really buy what you're saying. And eventually this patient, this was a Black woman, and she said, I just have a hard time trusting doctors. I hear that all the time. And I had just been reading Medical Apartheid that morning. And so I kind of looked at her, and I don't know that this is the best approach for every single patient, but what I said was, that makes a lot of sense to me because medicine has been really exploitive of Black people over the years. And she goes, yes, she was sort of like, yeah, you got it. And so we were able to kind of maybe take a step forward in our professional, patient-doctor relationship just by the simple fact of sort of naming some of those injustices and recognizing that healthcare has a long way to go, and we have a lot to sort of own up to in the past, and also current disparities that need to be addressed.
Well, and I think that's, I think that's a really good example of like what we need to be doing right now is like, like you have taken the steps to educate yourself on some of those atrocities that have happened, and some of the reason that those kind of trust issues would be ingrained in, I mean, like you said, going back to slavery. So it's, generation after generation after generation. And there's all these instances of where you can point to and say, well, yeah, this is why this distrust is there. So to be able to educate yourself and know why that person may be feeling what they're feeling, and then just know enough about it to say like, hey, you know what? Like, you're right. Like some terrible things have happened. You know what I mean? Like if looking at like the reaction from the patient, it's gotta be so validating to be like, oh, okay. Like he knows about this stuff, cause it's, I don't know. I'm somebody that if you are empathetic with me and you can show me that you understand where I'm coming from, I'm much more willing to kind of meet you halfway and work with you. So like, I'm the kind of person that I'd be like, yeah, 100%. Like, thank you. And then we'd be able to build that rapport and kind of go from there. The one thing I did want to ask is if I'm correct, the Tuskegee experiments were confidential for a very long time, right? If I remember. And that was, that's one of those things where there was always the conspiracy, and then it was later revealed that it was actually something that happened. Am I remembering that correctly?
Yeah, I think, how old are you, John?
I am 35.
I'm 35 too. When was your birthday?
Mid-February.
February 13th. What about you?
16th.
Oh man, so close. My daughter is February 16th.
Social security number. No,
oh, right. Okay. Credit card. I knew there was something up with this podcast. I knew it was a scam.
Yeah, I got a doctor on. Let's
if you would, let me give you my student loan PIN as well. If you want to go on there and make any payments, that's great. For our generation, I think by the time that we were growing up and sort of reading the history books, this was a known, this had already been sort of revealed. So I couldn't speak intelligently to what that was like for people growing up in the 60s and 70s, sort of thinking, I think there's something up there, there's sort of voices in this community that are kind of saying, hey, they're not doing the right thing by us. It seems like they're not giving us the treatment. I think it's really easy because we do have that sort of we have this cultural narrative of doctors are out to get your money, but we also have this sort of paradoxical cultural narrative of doctors are always altruistic and always want what's best for you. And we sort of pick and choose which one to believe based on which one suits our needs at the time, it seems like. And so I'm sure that there's a lot of pushback to that, to say, oh, I'm sure that a lot of people in our country would have gone, oh, it's this poor Black community in Georgia. They're not very well educated, and they're saying these doctors are out to get them and they're not doing the right thing by them. We can kind of dismiss this type of person's narrative. And it just shows the danger of dismissing someone's narrative for what's happened to them. I think it's something that we have to do on a broad level and also on an individual level. I hear stories all the time from individual people, white, Black, any ethnicity, any age group, any gender, who have these horror stories of what's happened to them in the medical field. Sometimes they very clearly don't make sense, but at the same time, do they only not make sense because the individual person doesn't have the vocabulary, the medical vocabulary, or sort of the scientific background to understand it? And I've also, I've heard narratives, and then once I've had the opportunity to investigate them, that person's narrative was actually really appropriate care. And it just was not communicated in a way that felt safe to the patient. The patient left going, didn't feel like that was a safe situation for me. But if we chalk everything up to that, if we chalk everything up to, oh, the patient just didn't understand what the doctor was trying to do, we do so at our peril, because there really are sincere abuses. And so I couldn't speak to whether or not that was the way that things were perceived with the Tuskegee experiments at all. But but it wouldn't surprise me if people kind of dismissed the claims that community was making of the way that they're being treated.
Well, and the reason I ask, and to kind of get to your blog, is
sure.
I have a really big problem with people who, I guess, when your brain sees everything as a conspiracy, then legitimate conspiracies slip by. You know
sure.
what I mean? Like,
sure.
Like, yeah, and we have had as a history, we've had, Operation Paperclip, where we bring over Nazi scientists and doctors, and they're like, forget everything that you did. We need to get to the moon. And we have things in our past.
Then, by the way, John, who then were allowed to pick and choose experimental subjects for subsequent studies, and predominantly chose people of color to continue experimenting on. So they did it in Nazi Germany. They were brought over by the CIA, or what became the CIA, and then they started experimenting on predominantly Black and minority and low socioeconomic status people here in the United States. So just to kind of link those two together. Yeah.
It's not surprising though, when you've got somebody like Werner von Braun, who would hang the slowest Jews that were working in his factory, once a day. He'd be like, no, you guys aren't moving fast enough, so come on, to kind of set an example that everybody needs. And then we bring that guy over and they're just like, hey man, help us get to the moon and you can do whatever you want. So it's I understand why people are weary of conspiracies, because again, as a country, we have a very real history of, there was that, I forget what the name of it was, but Charles Manson was arrested a bunch of times and just somehow kept getting released. And, there's a whole, the government was having him feed people LSD, and, it gets really, really deep, but there's legit conspiracies that we've gone through and that people have suspected and then turned out to be true.
Sure.
But because of that, then it's 5G is turning the ducks gay, and it's.
I haven't heard that one. Is that a legit people?
It's just one. It's so. I'm a technology guy.
Yeah.
And 5G is radio wave. So when it came out that 5G towers are what's causing this virus that you get inside, like a cult, like these waves cannot cause it's just not scientifically possible for, you can't hold a radio up to your head and then you've got the flu. It doesn't work that way.
Right. You need a plausible mechanism of action. Yeah.
Right. You need the aerosol transfer, you've touched it. And so my question to you, I guess I've got two questions. First, how, as a medical professional, because again, I'm just some Joe Smo. I'm not a smart guy. I played music and then I just really like talking to people on the internet. That's like, that's what I've got going for me. But I know that for me, seeing all of this, like every week, there's some new conspiracy that comes out. As a medical professional, I don't know how like you're not just like scratching at the walls going crazy. And then number two, is any part of that why you decided to start the blog? Because it's an amazing blog, and I want to kind of talk about some of the bigger things that are in there. But
sure.
Just wanted to give you kind of a chance to talk about like where it came from, because it's been driving me crazy. So I can only imagine.
Yeah. Thank you. I think the two things I would say to that is, I mean, we've talked a little bit about what I do day to day in clinic, and I think empathizing with people's personal narratives, sort of delving deep into the suffering that people have experienced. And then to some degree, as a doctor, being expected to come up with an answer, I mean, and a solution going forward, which I'd be the first to admit, there's a lot of hubris to think that's always possible, because it's not always possible. But oftentimes there is that burden to say, hey, some of this suffering has a biological source that can be addressed if I'm clever enough as a doctor at trying to help you get the treatment that you need. And so that is so laden with moral injury, and it's so emotionally fatiguing that, to me, just arguing with conspiracy theorists on the internet is actually pretty life-giving, fun, and relaxing. And so, it's I kind of do the blog to relax a little bit, because hey, these guys got their math wrong, but I can't quite figure out how. Let me try to work through this and try to figure out, oh, I get it now. This is where they made the error. I think I could explain that in a way that's a little bit more accessible. So it does drive me crazy, the misinformation, the way that it actually affects people's lives. But maybe not any more or less than it does just the general public. And the reason I started the blog was because I think it is easier for me as a physician, as a medical professional who deals in these realms every single day. I mean, my most recent post was just yesterday, and it was talking about this new sort of only 6% of the death certificates only had COVID-19 listed. Therefore, those are the only ones that count as COVID-19 deaths. It's only like 9,000 deaths. This piece of misinformation that's out there. I think that there are a lot of people who, like yourself, who would go, I know that's wrong, but I don't have the background or quite the experiences to say exactly why it's wrong. And so we really love to refute my aunt or my uncle, or gosh, we'll not be, ageist, but my nephew, who posted this misinformation meme. But I don't really know how to tell them what the real information is. And so for me, the goal with the blog was not so much to argue directly with people who believe in this misinformation, because they may not read a 7,000 word blog post, but to give people who know that they're looking at misinformation, just want to understand it better and sort of get the verbiage and the deeper understanding to sort of refute that and argue about that with people in their own circle. That was my goal, was to be able to kind of give someone the ammunition they need to say, hey, actually that's not how death certificates are done. I read a doctor's blog and he explained how we do death certificates. And here's why that 6% number doesn't mean what you think it means. Or here's why the statistics you're talking about can't really be interpreted, because we're not really talking about a case fatality rate when you calculate the numbers this way, or whatever it is.
Yeah, and one thing I will say about your blog is that I really enjoy the way that it's written, because it's not written. It's written from a personal point of view, as opposed to being like, oh, here's a dissertation as to why this is, and it's why there are like the facts and the statistics are in there. They're put in there in a very digestible way where it feels like, like you said, not to be ageist, but I think we all have that one aunt or uncle where you can be like, just please read this.
Sure, what I mean? Sure.
And the other thing that's since, we're talking about the 6%, like the way that I've likened it is like, I could suffer from severe depression, right? If I shoot myself in the head because of that depression, that gun, that bullet, that shooting myself in the head is what killed me. Sure. I had depression, but that depression didn't kill me. It was the act of doing that. So if I've got, terrible diabetes, or if I have COPD or some kind of like chronic lung illness or something like that, that's the depression. And then if I get COVID, that's the gun blast, essentially. It's like, you've got all these things, but this is what pushed it over the edge and basically said like, hey, you're done. And I, like you said, I don't think people understand how death certificates are written. Or I think the thing that even irritates me a little bit more is that, I mean, first of all, America we're a notoriously unhealthy country. Our obesity rates, I mean, I'm a fat dude. I can't help, like, I'm working on it, but I am. Like, our obesity rates are high, our diabetes rates are high. So we're already a country that is prime for, when this hit, we were going to be easy picking, essentially. So you're these people who are arguing are like discounting that, and then discounting it's like, oh, well, if you had a pre-existing condition, then COVID didn't really kill you. And so it feels like, number one, you're just denying science. And then number two, like, I can't imagine being someone who's like, yeah, my dad had COPD and then he got COVID and he died. And now you're trying to tell me that he didn't die from COVID. I would be furious. You know what I mean? So like, can you kind of break it down for people who may have heard that? Cause I've seen it on the internet a lot.
Sure.
Can you kind of break down the way that those death certificates are written and why that? I mean, you did kind of at a high level, but I want people to kind of be able to understand exactly what's going on when they see that 6%.
Sure, absolutely. And I think you kind of hit the nail on the head. The two pieces of misinformation there are, number one, that's not really how death certificates work. And number two, even if you were right, why don't those other people who had another medical condition, why don't they count to you? Is it just because the little bit of mitigation you were willing to kind of do, towards keeping people safe from the virus all along was only because of the personal risk to yourself and your loved ones and your children? And now that it's sort of, oh, we found out that only people with these conditions are at risk for the virus. I don't have that condition, so I don't care anymore. I mean, I think there's a disconnect there that really needs to be, there's some soul searching that needs to happen if people are kind of sharing it because of that purpose. But I think really the bigger point is just any piece of misinformation, no matter how bad the math is, no matter how disconnected from reality it is, anything that says these numbers are very, very small is going to be latched onto. We saw that, back in May with the Bakersfield doctors, the California guys who were saying, very, very large number of cases, very, very small deaths, over and over again. And their math was totally wrong. So the way that we do death certificates is, and I've only done maybe a dozen of them over the years. I have friends who do hospice care, like I mentioned on the blog, who've done hundreds and hundreds, because it's a big part of what they do is helping people during their last days. And so the way that we do that is we start by, it has a line that says, what was the immediate cause of death? And so oftentimes this is going to be cardiac arrest. And in fact, so common is your heart stopping is technically you dying, unless it's brain death, which is more rare. So your heart stopping is how you die. And so some doctors don't even include that. It's sort of like saying, if there's a diagnostic code for death, you wouldn't put death as the first cause of death. And that's what cardiac arrest is. Right. I usually do start with cardiac arrest. So you might say, okay, cardiac arrest, their heart stopped. And the next line is, well, what caused their heart to stop? And you say, well, their heart stopped because they were in respiratory failure. Well, what caused them to be in respiratory failure? And here's where you go, well, they had a pneumonia. So, okay, well, what was the cause of pneumonia? Well, the cause of pneumonia was actually adult respiratory distress syndrome. Well, what is the cause of the adult respiratory distress syndrome? And the next line is COVID-19. So already there, all you've done is you've described someone dying from only COVID-19. You haven't talked about any comorbidities. You haven't talked about any pre-existing conditions. You haven't even talked about, is this person diabetic? Do they have obesity? Do they have hypertension? Are they a smoker? Do they have COPD? Do they have congestive heart failure? You've only described death from COVID-19, and you've got 5 diagnostic codes. And so the point I try to make on the blog is, if you've only got one diagnostic code, that's that 6% of death certificates only have that one diagnostic code for COVID-19. What happened when you were filling out that death certificate, man? Like, why didn't you spend a few more minutes trying to describe the process? And maybe it's because people were entirely overwhelmed. Maybe it was, sort of some younger doctors who were brought in the field to deal with the pandemic who didn't quite have the training for how to do those certificates. But my friend who's a hospice doctor, who's filled out, 500 or more of these death certificates the last few years because they do so much hospice care, said, I think I've listed only one cause of death, maybe twice. And it was like that person who was previously healthy, they have a cardiac arrest out of the hospital and they die. And you go, well, they had a cardiac arrest. We can't quite figure out why without an autopsy.
Everything else looked good.
Yeah, exactly. And the quandary comes in. So you've got this. So you've got 5 diagnostic codes for this, COVID-19 death or this influenza death or whatever it is. And then the quandary comes in with: do you take things like? So for me, I use the example high blood pressure and high cholesterol, or take diabetes and COPD. Do I list these in that sequence of events as actual causes of death? Like, actually, this led directly to me getting COVID-19, which led directly to ARDS and directly to respiratory failure and cardiac arrest. Or do I just include them in the second line or the second part that lists all the comorbidities? And I've had patients who, you would list any comorbidity that you really thought contributed. So if you've got somebody, I'll use myself. If I get COVID-19 and die from it, we'd probably list high blood pressure and high cholesterol. We wouldn't list this right shoulder pain that I have, or that weird, that weird toe issue I had a couple of years ago. Those don't get put in the death certificate. And so because the doctor who's doing it doesn't think they contributed. So what we do know is for the 160,000 death certificates that listed COVID-19 that are part of this data set. And of course, now we're up to, the 180s, but at the time this data was made available was 160. Every single one of those represents a doctor or a coroner, someone who's completed a death certificate, who believed, with no financial compensation to them, with no, briefing from Fauci and Bill Gates the day before or anything like this, they believe, based on their understanding of what happened to this individual person who had passed away, that COVID-19 contributed. We don't know how many of them listed as in the sequence of events that says it directly contributed. We don't know how many of them say, well, this patient died of this, but I think the COVID-19 contributed to their death. But we know that those do not include people who were found to die incidentally, or found to die and then only incidentally have COVID-19 and it wasn't a factor. So that whole idea of you get hit by a bus and you die on the spot, but then the autopsy reveals you have COVID-19. We're going to put that on the death certificate. That's a myth. I think there have been, you could count on one hand the number of cases where it's actually shown that was done by error, as opposed to this big sort of conspiracy that says this is happening all the time. And just to go back to, your point with the depression and suicide by firearm, I think, there's going to be a quandary for the physician to say, obviously gunshot wound is going to be, the primary cause of death. But do I think that the depression led directly to it? That's going to be a part of the sequence of events. So when you ask the question, how many people die by firearms, that person's death is going to be included. When you ask the question, how many people died from depression, it's going to be included in that one too. And so it's not sort of an either or, it's a and or, it's a and also type of question. Because when you add up the total number of deaths from heart disease and from diabetes and from cancer, it adds up to way more than the number of people that died, because you could easily die from all three, the same way that you could easily die from congestive heart failure and COVID-19.
Yeah. And I mean, that makes a lot of sense. I think, it's just like, it just blows my mind how someone can latch on to, well, you see, like, they're lying to us. Like, there's this need that, and maybe you can speak on this because, you mentioned Dr. Fauci and Bill Gates, right?
Sure.
So there's this conspiracy that, for every COVID death, hospitals are getting X amount of money. And this is just a deep state attempt so that we can, have Bill Gates vaccinate you with a microchip. And
right.
And the whole time I'm yelling, you carry around a cell phone, your microchip and your phone knows where you're at all
They've
times.
already got you. Yeah.
Right. They don't need to you pay for everything with, you do everything with your phone. So, I know a big thing is, it seems like with doctors particularly, there's two sides of the coin. It's either you're all in on it and you're all part of this massive, global conspiracy, and your family medicine practitioner is now some deep state sleeper cell agent. And then there's the other side of the coin where it's oh, well, they don't know that they're being played in this, this big, they're a pawn in this giant game and stuff. So how do you combat those people, or those because I can imagine if I'm going into work every day and my job is I'm just here to help someone, to either be accused that I'm not smart enough to know what's going on, or I am smart enough to be part of this giant deep state cover up, has got to be something that, again, for me, I'm not a doctor and it drives me crazy to know that people think like that. So
Right. We're kind of both. It's sort of like, hey, you guys are these masterminds, but also you're too dumb to know that you're being used. And it's sort of there is a little bit of a there's an oxymoron there in the way that you sort of you're both. You're both really, really smart and really, really dumb. Hey, John, I want to ask you real quick. I really need to go and check and see how Dr. Fauci wants me to answer this question. Oh. So let me just go text him real quick, and I might use the bathroom while I'm away. I'll be back in just a minute. Okay.
All right. Cool. All right. So we're back, and so we were kind of talking about, how you were dealing with that, either you're smart enough to know what's going on with this deep state ploy, or you are just being played, you're a pawn. And I know that you had mentioned it's kind of frustrating because people are like, yeah, you're smart, but you just don't get it. So I don't know if you had any finishing thoughts on that. Or
Sure. I think I think the most frustrating, I said before, I kind of argue about medical misinformation to relax. But the reality is the most frustrating part of it for me is arguing with people who are willing to shift their ground the moment that you challenge their conspiracy theory or their argument. And that's really what that is. It's this idea of well, all you doctors are just intubating people because you make more money off of it. You're putting COVID-19 on the death certificate because you're going to get some kickback from that. And then you sort of say, well, actually, we're not. It goes back to that whole hey, I know more bad doctors than you do, and I can't think of a single name on that list of people I would consider bad doctors. And like I said, it's a pretty short list. I can't think of a single name of somebody who would do that. And so because they either say, well, yes, you are, and you're a liar, but people, as confrontational as our society is, we're still not quite to the point of just saying you're lying to me, or maybe we're not always to that point. And so instead, the solution to that is to kind of shift your ground and say, oh, well, then you're just dupes. You've been duped, and it's the hospital administrators that are doing it. And then the hospital administrator, across the hall goes, no, we're not doing that either. And then and
we're just going home crying because this is the most insane time we've ever lived through.
Yeah. And I know, I know personally one hospital administrator, and he's a really great, honest guy with a lot of integrity, which really challenges my conception of hospital administrators. And so part of me wonders if they're doing the same thing, if they're just kind of going none of us are doing that either. And I know more about hospital administrators than you do. And most of them are just trying to run their hospital as efficiently as possible, and they're accountable to the board, so they're trying to make as much money as possible, but it's not this sort of shady sort of twirl your mustache type thing. So I think people who are kind of every time you show that their point doesn't really hold water, they're going to shift their ground. They say, well, if it's not the doctors, it's the hospital administrators. If it's not them, then it's the CDC, and the CDC kind of releases this data. And the one that kills me is, a few months ago, we were being told by the conspiracy theorists that doctors are lying and adding COVID-19 to the death certificate. So the death certificates are totally unreliable. And of course, now the most recent thing is, look at this reliable death certificate information. Right. It shows that only 6% of the deaths are from COVID-19. So it does. It makes you want to pull your hair out a little bit. And I think the best thing that you can do is sort of say, this is what it really looks like from the other side. This is what it really looks like to fill out a death certificate. Here are the decisions that I have to make before I put somebody on a ventilator. And none of them have to do with sort of pulling out a calculator and deciding if I'm going to get a bonus check or not. And most physicians aren't even compensated that way. Some are, in terms of if they're doing higher level care and they're doing certain procedure codes, they get paid more. But for most people, the amount of money that they would make by taking care of one higher level patient or a couple of higher level patients would be very negligible compared to their salaries and other bonuses and that sort of thing. And it would by no means justify sort of this lapse of their professional obligation to the patient, their medical ethics, or their morality. Even if the $23,000 that you're supposed to get if you put COVID on the chart, or the $46,000, I don't remember the numbers from the conspiracy theory, even if that was going to the doctor's pocket directly, which probably zero of that would go to the doctor's pocket directly. Right. I think the overwhelming majority of physicians I know, that would have zero influence on whether or not they would make the decision to intubate a patient. Because we're in the habit as doctors of not really putting our own economic self-interest first. We do it all the time when we kind of say, hey, I'm going to spend more time with this patient, even though it gets me $0 extra in kind of clinic income, because this is what the patient really needs from me. Or, another thing that we do all the time is we go, hey, I really need to see you in 2 weeks, because that's what we need to do for you medically. It makes more sense to see you in 2 weeks and touch base on this. And then I'll usually kind of go, but what's your copay? And if the patient goes, oh, I don't have a copay, I go, great, let's schedule that visit in 2 weeks. And if the patient is somebody who's economically disadvantaged and they go, oh, it's a $20 copay, I go, oh, we could probably just do that as a phone call, which is of course something that doctors don't charge for the way that like lawyers do. I could probably just let's do a phone call in 2 weeks. And then would it be affordable to have that $20 copay get in a month? So we'll talk in 2 weeks and then come back and see me in a month. And I think we can provide pretty much the same level of care, even though obviously that brings in less income for the clinic, that brings in less income but my salary is not really calculated, that way, that it depends on how many patients I see. But obviously it's in our economic best interest to sort of schedule a visit instead of do a free phone call. But the branch point for that decision is based on how much money it's going to cost the patient. We do that all the time. It's a habit for us. And especially when you get into really high level interventions like intubation, like starting a central line, like doing a surgery, the economic question is so far down the list for your normal doctor, as it should be, that I think people just don't get that. To them, they see it as a used car salesman. Like, hey, if I can get you the deluxe package and the undercoating or whatever it is, then I'm going to do that because that's my business model, and that is just not the way that physicians are trained or the way that we think about patients' lives.
Yeah, it's so funny too hearing you talk, because in the beginning you mentioned you were like, yeah, I wanted a job where I was going to make a lot of money. Yeah, so being a lawyer, and then you get older, you get to the point where you are now, and it's like, well, let me just call you because I want you to save that money. And it, like, I don't know. I think it's I think it's very interesting when you meet someone who doing good again is kind of like ingrained in who they are. Because you could say like, yeah, like I want to make so much money, but then every choice that you've kind of made as you've gone through, I mean, not that you don't do well, but you're obviously not someone who's like, I put the dollar before everything. You know what I mean?
Sure.
Again, right now, especially when we see people like Jeff Bezos and all these conspiracy theories about Bill Gates, when you see these people who have this uber amount of money in the way that they're being portrayed and things like that, it goes to show that like, hey, just being a good person and trying to help other people definitely seems like it has more of at least the social reward with it. And then the other thing is you can't take any of that with you. You know what I mean?
Absolutely.
It's not like,
absolutely.
Unless Jeff Bezos is going to open an Amazon in heaven, but I don't know. I don't know how that's going to work.
That's funny. Yeah. There's, I think, when you look at this, gets dangerously into self-aggrandizement. So I always kind of hesitate to say things like this. But when I look at the people that I've worked with over the years, and just the amazing talent I see in people I went to medical school with, people I did residency with, they could have done lots of things. They had the skill set and the interpersonal skills and the talent to do lots of things that would have made them a lot more money than becoming a doctor. And so I think, even though I have nothing to complain about with, physician salaries, I could complain all day about student loans, and where, I'm looking forward to the day when I'm more valuable to my family alive than dead, because my student loans are non-transferable, and that sort of thing. But student loans are a problem, but as far as like the salary and the lifestyle it allows us to live, and sort of feeling like just the immense privilege of not having this horrible economic burden, through something like a COVID-19 pandemic. I mean, it's really, I'm very grateful for that. But I know lots of doctors who could have made a lot more money, and several who did make a lot more money, and they left that career to pursue medicine because they wanted to do something that helped people. And so, so when you ascribe, you're talking about these conspiracy theories, when your conspiracy theory depends on people who tend to be pretty altruistic suddenly being nefarious, or it depends on people who are pretty smart suddenly being really easy to trick, or it depends on people who are usually pretty prideful and I'll say even conceited. We have that in medicine, the old joke about what's the difference between God and a surgeon. Well, God doesn't think he's a surgeon, but of course the surgeon, thinks he's God. There is some pride and some conceit in medicine. I'm probably not entirely free from that myself. But when your conspiracy theory depends on people who are pretty prideful about what they do, suddenly sort of kowtowing to this global conspiracy that tells them what to do, and they're kind of meekly subservient to it. I mean, you've grossly misunderstood the character of physicians and nurses and nurse practitioners and physicians assistants and all these people who do this work when you think that they would go along with some conspiracy like that. And that those one or two doctors, the America's Frontline Doctors and the Bakersfield guys.
Oh, we're going to talk about the American Frontline Doctors.
like that these are like the whistleblowers, and you've got, 10 whistleblowers out of the million doctors that you have in America, instead of all these people kind of blowing the whistle on these conspiracy theories that supposedly exist.
Yeah. And I'm with you as far as like when someone's willing to shift their ground, because that's been the most frustrating thing for me is that, we were kind of talking about it earlier. It was like, when this all started, it was 5G towers, and people were literally burning down cell phone towers in the UK. And then all of a sudden that just went away. And that wasn't right. Okay. Well, it's not that. So now it's, now it's got to be this new world order agenda. And it's just like, again, kind of going back to, if like everything is a conspiracy theory, and what everything that the media tells you, and don't get me wrong, I definitely think the media does a terrible job at plenty of stuff.
Sure.
However, I don't think that they're, purposely trying to turn this into, I hear the sheeple, following, and it's always the other side's news. It's never, it's always CNN. Nobody talks about, Fox News or vice versa, but you had mentioned America's Frontline Doctors, and sure. When this video came out, I watched it, and then I looked up who some of these people were. Like sure. I looked up Dr. Stella Emanuel. I forget, I'm blanking on her name, but she was the woman who opened up and introduced, like, was
Dr. Simone Gold,
yes,
I think. Yeah. Mm-hmm.
Who, when you look her up, you find out that she, she wanted to be in Congress. She was like a page or something like that, like trying to get into politics and government. And sure. Now she's doing this Breitbart sponsored,
Yeah.
And so you look at like Dr. Stella Emanuel, I mean, she kind of she was kind of the star of the show, but she's saying that she's, treated all of these patients with hydroxychloroquine, and we don't need to wear a mask, and there is a cure, and that, they just don't want you to have it. So before I kind of dive into some of her questionable stuff,
sure.
As a physician, when you see another doctor, and I'm hesitant to even say, like, because I know she's a doctor, but part of me, like, in the core, like, feels hesitant to be like, oh, this physician. But like, as somebody in that role, when you see somebody come out and say those things, like, are you just like shaking your fist, like screaming at the computer? Like, because I don't know. I was just like, everything that you're saying is like, wear your mask, social distance. There is no cure. I was just freaking out. So, I mean, I don't know. Yeah. Like, is it a similar thing for you? Or are you just so kind of with what you do with the blog? Are you just so inundated in it that it's just like, just another, crazy thing somebody has to say?
Yeah, I think there's, man, what a good question. You're so good at this. You're so good at asking these questions. You not to make a weird comment that you might have to edit out later, but you remind me of my wife. She's so good at conversation, and she just comes up across the dinner table with new friends and this kind of thing. She comes up with these questions, and I go, "How did you even think to ask that?" You know, and that sort of thing. I think it's a fair question. I think there's a degree of sort of moral injury that occurs when you see sort of other physicians who, knowing full well, they've had the same experience of working with thousands of doctors through medical school and residency and practice that I've had. And many of those doctors are much more experienced than I am. And so the two things that I wonder are, have they just, the question I had to ask with Dr. Lozano, she was the big hydroxychloroquine at the Set America Free rally back in April or May, was, have you just been burned by the system so many times? I don't know people's personal history. I don't know if they really feel that they have, by the other physicians around them, by the hospitals they've worked with, by people in medical school and residency, and ever since, that they've been ostracized or burned or let down or betrayed by other doctors, to the point that they have sort of, that they have a personal narrative that other doctors besides me can't be trusted, and I think that would be a really hard thing to do. One of the things that makes this job survivable is having peers and having, some camaraderie and people who have been in the trenches with you. They're having the same struggle. They know what it's like to be desperately trying to help the patient in front of you and have that person scream in your face for any number of reasons. That they know what it's like to have to call CPS on a horrible child abuse case when the parents are maybe doing the best they can, but it's just a terrible situation all around and nobody's at fault. All these horrible experiences that we accumulate doing this job, you need other people alongside you. And so when I hear doctors who are kind of willing to sell their entire profession under the bus, or throw their entire profession under the bus, I have to question what their experiences have been, that they have such a low opinion of their own profession. And then the other part of that is, I think that's the gracious view. The other question is, are there financial or political, motivations there? Certainly, if you get on TV and you say, if you come to my clinic and you think you have COVID-19, a lot of these doctors, they say, I don't really believe in the tests, so I'm going to treat it like COVID-19. And by the way, if you're asymptomatic, I'll treat it like COVID-19 too. So what you've basically said is, if you're asymptomatic and you don't have a test and you don't have a known exposure, so basically if you think, hey, if you're sitting in your living room and you think, maybe I've got COVID-19, if you drive to my clinic, I will put you on these 6 medicines, and I will yell and cuss at a pharmacist if they don't want to give them to you. And I will get you treated with the hot button political medicine that's being pushed right now as the cure. And so when you say that, you're inevitably going to get people Googling where your practice is and driving to you. And again, it's all kind of comes back full circle. So when that doctor then goes, I've treated hundreds of patients this way and they've all done really well, you have to go, yeah, but a lot of them were asymptomatic. They didn't have any exposures. They literally drove across the state to come see you because you were on YouTube. Right. And you said you were going to give them the medicine. They say, and then you get kind of included in their personal data set of patients who did really well with their treatment. So I do wonder about personal and political motivations. And at the end of the day, the place that I have to come down to is you look at someone like Dr. Stella Manuel, and she does have some very heterodox religious beliefs. She has some very interesting comments that she's made and sort of sermons that she's preached and that sort of thing.
That is the most polite way of saying that.
Sure. And ultimately what I want to do is I want to show on the blog why the arguments that she's making about medications, about masking, why these are incorrect. And oftentimes it's common sense stuff. When she says you don't have to take precautions to keep from getting the virus because we have a cure, that sounds like, oh, good, we have a cure. They've been lying to us and hiding it from us. But that is a 180-degree shift from what we as a society have accepted about health and medicine all along. I bet the essential oils people were pulling their hair out when we said you don't have to worry about prevention because we have a cure, because alternative health people and nutrition people, and obviously there's good things to glean from from some alternative health sources. And there's some good things, lots of good things to glean from people who are emphasizing nutrition and that sort of thing. But the people who are sort of a little bit crunchier in the way they approach medicine were probably screaming at their laptops, because we've known as a society for thousands of years that an ounce of prevention is worth a pound of treatment.
Right.
And so to suddenly shift that and say, hey, just drive to me and I'll give you some hydroxychloroquine, you don't have to worry about wearing a mask, is ridiculous. And so that's what I wanted to focus on in the blog.
Well, and that's one other thing I did want to ask you too, because I know, one of the articles that you did on the blog was, about people kind of conflating COVID-19 to sex trafficking cases and I think especially right now, I mean, obviously there's the whole like Save Our Children, which started as like a very noble thing, but then gets hijacked by a group like QAnon. And now it's, Tom Hanks and Ellen DeGeneres are, I mean, I'm sure the whole thing, but I think the frustrating thing for me there has been, my wife before, my wife is in social work, so she worked for the domestic violence program here in Tennessee. And when you, you can attest to this as somebody who volunteers, but like when you work in that field and you're helping people who've been victims of these things, it feels like, all these like Tom Hanks and this and that is like, you're shifting the focus off of real victims, real perpetrators, real people that need your help to throw up a hashtag and, Democrats are eating babies and drinking blood and doing all, this crazy stuff. So, I mean, as somebody who is in it and is like fighting, how do you not like let that get to you? Because I mean, for me, I would just be like, it would be mad. Again, I think this is why you're much calmer than I am. So I think this is why you're suited for the role that you're in. Because I'm just like, I'm so this drives me crazy. So
I think the human trafficking blog post, when everybody started popping up with sort of the memes or the macros that said, human trafficking, child sex trafficking is the real pandemic. I think that was the one that probably got to me the most, because this is something we've been so passionate about for so many years. And it's really interesting, the training that I brought to those medical students. And we me and one of my partners have done these medical school trainings and these healthcare trainings at different hospitals and facilities and medical schools kind of all over the state. And one of the changes that we made was we took out one image that was in the training, which was, you couldn't even really call it sexually explicit, but it had sort of two teenage girls, and they were sort of in cutoff blue jeans and sort of, smaller fitting tops. Southern Baptist kid growing up, clothing I wouldn't have considered modest, but these were pictures of people who were sort of in the life that, they were on the street and that sort of thing. And so you couldn't really even call it sexualized images, but we took that training out because one of the standards that had been kind of updated from Texas Department of Health and Human Services regarding medical human trafficking training was it needed to be free of any sensual or, sexual or sensationalized imagery. And because what you're doing is you are creating this sort of indelible impression of this is what human trafficking looks like, when the reality is that human trafficking is extremely variable in its presentation. And traffickers use all sorts of different means to control people. Most of them are economic and emotional. You very rarely see sort of handcuffs and chains and people tied up and that sort of thing. And so when all these images started coming out with, and I'm a father of four. I have two daughters and two sons, all under 8 years old. And when these images started coming out of like, a 5-year-old girl tied up with a dark figure standing behind her in a basement, and people were sharing this on Facebook, saying like, this many children disappear each year. What's the real pandemic? Sex trafficking is the real pandemic. it got my blood boiling, because I go, you are exploiting this imagery. I don't even know what photographer took those pictures and what parent agreed to.
Or even if a parent did agree, like where did it come from? And now you're just using it. Yeah.
Yeah. So you're sort of exploiting these sensationalized images to spread misinformation about what human trafficking looks like, to distract from a pandemic that's also hurting people. And so I kind of go, you can care about human trafficking and COVID-19. It's possible to do both. In fact, the day that the last human trafficking lecture I gave, I saw 14 patients for COVID-19 symptoms in the morning and saw 12 more in the afternoon, and just gave that lecture at lunch, kind of doing some training on human trafficking for our residents. And so you can care deeply about both issues, but how dare you spread misinformation about both issues simultaneously, because you think it's going to give you the moral high ground. You can say, oh, I care about child sex trafficking. You only care about this fake virus that Bill Gates made up or whatever. And I just think, if you spread misinformation about human trafficking, all you're really doing is helping the traffickers. And we need to have real narratives about what human trafficking actually looks like, so that people who are in service fields like social work, like medicine, like law enforcement, like the criminal justice system, like schools, can actually learn to detect human trafficking and sort of help get support to people who are being victimized through it. And so posting all these really cringy, creepy images of children, with hands over their mouths and tears in their eyes and this sort of thing, it's deeply disturbing to me.
Yeah, it's I have a family member who, her intentions were and that's what I have a hard time with these conspiracy theories too, is that I feel like a lot of people have good intentions, but they don't realize what it is that they're putting out there, because you see something like, hashtag save our children. And it's like, sure. Well, yeah, like I agree with that until you start looking at it, like looking into like where that came from, or, and, this family member, she basically was like, like the more I look into it, the more that I think that, there's probably all these Hollywood elites and, they're just trafficking these kids and doing terrible things. And I just told her, sure, statistically, there's probably some people trafficking humans in Hollywood, probably the same way that there's probably some dentists that are trafficking you, and probably the same way that there's some people that work at Target. Like statistically, sure. Unfortunately, these kind of people, go across the entire spectrum. Yeah. But, does it do more good for you to post a hashtag, or does it do more good for you to donate to an organization that's fighting, human trafficking? Or does it do you more good to say, hey, let me go volunteer my time? What do you guys need? Like, how can I help? Or starting a fundraiser, doing something like that. Like just don't. I think people with good intentions are really easy to get swept up into this, but then they're again kind of what you going back to people that are doing missionary work. Like you're trying to do something good, but you don't realize that like you're on the opposite side of that coin.
Yeah, the unintended harm that comes from that. Yeah, I think you're exactly right, John. I think, we have to draw the distinction. I'm sorry to do it 2 hours into the talk. No, you have to draw the distinction between the people who are creating this information and the people who are sharing it, because I think that's an education issue. I mean, certainly there are some people who you can educate them about the misinformation they're sharing, and they're going to say, and I've had people say it to me, I'm going to keep believing. I hear what you're saying. I'm going to keep believing it anyway. But for the most part, I think the people who are sharing the misinformation, they're sharing it because they hate this pandemic as much as the rest of us. I'm an extrovert. I miss hanging out at restaurants with friends and, meeting people at the bar and hanging out and taking the kids to a restaurant and sitting inside. And, I miss free refills on chips and salsa and all these things.
We get the large cheese dip every time because we're like, we got to bring it home. So got to make sure we have enough.
Yeah, queso blanco. You need the best stuff is in Texas, but I think you guys already knew that. So, so I hate this pandemic, and the people who are sharing this information hate the pandemic. And And what they're saying when they share that misinformation, I truly believe what they're saying is, oh, good. It's not as big a deal as we thought. It speaks so deeply to our deepest hopes that say, can we please just go back to normal? Can we please just be done with this? And so people who are sharing it, they're not kind of, trying to make it more likely that more people are going to die from the virus. The people who are sharing anti-mask information and, all this stuff about, death certificates and all these kind of lies, what they're doing is they're reading that and they're going, oh, thank God that things aren't as bad as we've kind of believed that they were. Can we please get back to normal now? And so I think when you're combating misinformation, what you have to do is you have to approach people with some degree of compassion, just like we should when we're talking about politics, just like we should when we're talking to people, when we're talking to those evangelicals who are supporting, a politician that we can't agree with. We have to approach that with some compassion and some understanding. And the same with people who are sharing misinformation, to say, hey, I get it. I get why this is so appealing to you. Can I please give you the information you need to realize that this isn't true? And then with some humility, because gosh, if the next set of viral videos coming out claiming that, XYZ medication really is a cure for COVID, every single time that happens, I really hope they're right. Because I would love to have, I've seen hundreds and hundreds and hundreds of patients for COVID-19 symptoms and diagnosed a lot of people with COVID-19 over the last several months. And it would be so great to give them the silver bullet medicine, if such a thing existed, to ensure that they wouldn't end up in the hospital, that they wouldn't have a bad outcome, that they wouldn't die from this or spread it to their family members. I would love to just have that. I'd carry it around in my fanny pack and just sort of hand it out like, hey, these are Tic Tacs and they're going to cure your COVID-19. We don't have that medicine yet. Maybe enough research will be done. I'm not hopeful or optimistic that it'll happen. But if it does, I don't want to be that guy on the internet going, no, it's probably not true because look who's saying it.
Right.
We have to have some humility when we approach those questions.
Yeah. And that was my whole thing. I mean, to get back to hydroxychloroquine, that was my whole
thing. We made it.
Was like,
yay.
Yeah. I was like, sometimes it makes you feel like the jerk because you're like, I would love for this to work. I would love if we could give it to people and it would knock it out and then everybody was fine, and we could just go about our lives. And I think you're right. I think that people so badly want like some miracle kind of thing. And that's where a lot of that comes from, is just kind of like, oh, like I'm just like holding out hope that maybe there's something out there, and it makes you, I mean, at least for me personally, like I've gotten into arguments or like, well, they gave it to people at Henry Ford and it worked just fine. And I was like, they also gave him steroids.
Yeah.
Like, but you don't read that. Like it hasn't, but, and then which was like, listen, I want it to work. I wish it worked. You just, get in this loop of like, I don't know. You just feel like you're like the glass half full negative Nelson all the time. You know what I mean? So
yeah, it's so easy to latch on to sort of one study without sort of any thought to the quality of the evidence and how the study was designed. And so one of the things that I've always found fascinating since the beginning of medical school was you almost go into it going, I'm going to find a way to tear this study apart, even if it's saying something you really want it to say. And then when you get to the end, you go, I can, that study was actually really, really well designed, or you go, oh, this is a big error. Now, that's an easy thing to do. It's easier to be a critic than it is to actually do research. Mm-hmm. I don't know that I have the intellectual patience or the internal characteristics to be a good researcher. I think it's really hard to design good studies, but it's easy to tear them apart after the fact and kind of, oh, they didn't do this and they should have done this. And so when you look at the Henry Ford study, I mean, this was an observational study. They weren't trying to do research. They were trying to treat patients. And so you're exactly right that the big confounding variable there was that, a large percentage of the people who got hydroxychloroquine also got systemic steroids. A very small percentage of the people who didn't get hydroxychloroquine got systemic steroids. And so that's a huge confounding variable, because then you look at something like the recovery trial that showed, dexamethasone. This is a randomized control trial. There's a higher level of evidence. This is a more reliable way of gathering data. And it shows that systemic steroids reduce the mortality for the sickest, ICU level COVID-19 patients by about 30%, which is awesome. I'm so thankful that we do have some medicines now that are actually really effective. And so when when people look at something like an observational study and they say this one observational study or this handful, this cluster of studies showed a benefit. So why don't we just try it? I think what they're kind of ignoring is that when you have large-scale, well-designed, randomized controlled trials, that is the gold standard of evidence. And so it's not that as doctors we're looking at that and we're going, oh, some studies say you do, some studies say you don't, maybe I should just try it. What we're looking at that is we're saying this more reliable data shows us that the confounding variables in this less reliable type of data were really what caused that positive effect. And so it's not that it's unclear or it's sort of, dealer's choice and that kind of thing. It's that really the evidence is in, at least from all the studies that we have right now, to say that, budesonide or hydroxychloroquine or azithromycin, whatever it is not the magic bullet that's going to prevent you from going to the hospital. Or from ending up in the ICU. And I could look at a patient in the eye. It's easy to sort of look at somebody over a video and lie to them. But I could look at you in the eye and say, if I found out tomorrow that I have COVID-19, I'm not going to try to get one of my buddies who's a doctor to write me a prescription for hydroxychloroquine. But early on in the course of the pandemic, when it looked like that was the direction we were going, there were some early positive results. I knew doctors who were really, really enthusiastic about hydroxychloroquine well before Trump ever mentioned it, because the conspiracy is that we just don't like it because the president said it. But I know plenty of people who are excited about the prospect. Heck, I think the first time that a friend posted on Facebook, another doctor friend in Dallas posted on Facebook, hey, it looks like hydroxychloroquine and azithromycin might be the treatment of choice. And I went, great, weapons to use against the virus. I mean, it was this really nerdy kind of post. I was like, plus one great sword against COVID-19 or whatever, and then we remained enthusiastic after the president mentioned it. And it wasn't until the studies came out that showed that the higher level evidence really didn't support using in the outpatient setting that, we kind of went, well, that's really unfortunate. That's too bad. I really wish it did work. And if a new randomized controlled study that's really well designed, that has a large number of participants, was published tomorrow that showed that I should be giving all 115 patients, that I'm evaluating for COVID-19 in the clinic, that I should be giving them this medicine or that medicine, and the evidence is reliable, obviously that's going to play an incredibly important role in my clinical decision making. And so I think, I think recognizing that you can't just take 120 people's lives and kind of roll the dice and say, I don't really have any evidence, but I have a hunch, or I don't really have any evidence, but politically I feel motivated to give you this medicine. That's not really a legitimate way to practice medicine.
Yeah, I agree. Like I said, I'm not a doctor, but it sounds like that's the right way to go about it. And that's the other thing too, is I don't feel like it's a bad thing to get enthusiastic about something that may work, but exactly what you said, once it showed that it didn't work, okay, now what do we move to? What do we need to test now? And I think the other thing that, a lot of people don't think of is that, hydroxychloroquine, if I'm correct, is used for malaria. Is that? Yeah.
I mean, it's an anti-malarial. We also, use it for lupus as well, which is why I prescribed it for both. But
yeah, so you've got people who genuinely need this medication, and then if there's just doctors writing it for people who don't need it, then you're looking at medication shortage or cost hike, and it's just I think it's kind of what we were talking about earlier. You drop that rock, and then it just ripples out. You can have those positive ripples or those negative, you know what I mean? So
yeah, there's definitely some unintended consequences down the line. I think, which would be a small issue if it really worked. If you really said, hey, every single patient, I think my county had 100 new cases of COVID-19 that were definitively diagnosed today, which means there's going to be an extra kind of layer of false negative tests that we didn't diagnose, but that probably do have it clinically. And so if you said, hey, we need to give every single one of those patients, hydroxychloroquine or some other medicine, then it's up to us as a medical industry, which I kind of hate that term because I consider myself part of the medical field, but it really is up to us as a medical industry to then rise to the challenge and meet that need. But when the need isn't there, when we don't actually need to give all those patients this medicine, but yet the medicine is being hoarded by individuals or by clinics or pharmacies, and then people can't access it when they need it for their chronic medical issues, then it does become a problem where you say now this misinformation is directly kind of hurting people.
We've been going now about 2.5 hours. So,
oh gosh, I'm so sorry. You're gonna
it's good. And I've really enjoyed it. I just think that's kind of a good spot to wrap it up. Is just kind of on that note of positivity. Let me ask you this: if obviously. You guys, if you're listening, you can go to TJ Webb. That's WEBB. MD.com. We'll put the link in the show notes for YouTube and everything like that. Please go and read the articles and things like that. But is there, as a physician, is there, of course we want people reading your blog, but like what else can people do that want to stay informed, that may kind of want to, again, not to just win an argument or go against that uncle and aunt, but there's so much noise out there. I mean, other than reading your blog, is there anything else that you suggest as far as, how someone can kind of keep their head on their shoulders?
Wow, that's a great question. And I think, I think you need to start from the standpoint of, if you really think that your local doctors are out to get you, they don't care about you, they only care about making money, you probably need a new doctor. If you genuinely believe that's the case, then you need to change your primary care physician and that sort of thing. Because in general, most people in healthcare, most doctors, most nurses, physical therapists, they're in it because they want to see people well. And they have spent a long time sort of gaining the skills and the knowledge base and the patterns of thinking and analyzing data to be able to sort of parse this information. And so when the information when it seems really too good to be true, or when the information's coming at you and it's really easy and straightforward and unnuanced and doesn't have much complexity to it, and it's really easy to digest, I would be suspicious of it. And I would turn towards, people who have devoted a lot of their time and energy and made a lot of great sacrifices in order to be able to promote the health of the community around them and your health specifically as a patient. And so I would say trust your doctors. Doctors haven't always been trustworthy. We've talked about that a lot in the show. But if you think your doctor isn't trustworthy, then you need to get a new doctor. Because in general they are. And in general, they want you to be well, and they are looking out for your interests and that sort of thing. And so I would think be wary of trusting narratives that require people who are really working behind the scenes for your good to actually sort of be working against you and be trying to pull one over on you and being trying to sort of keep you in poor health or expose you to something that's dangerous or pull the wool over your eyes. That's the part that really gets to me is as physicians, we make these heroic efforts that are never seen by anybody, to try to get some semblance of healthcare justice or equity for our patients, or even if it's not a justice issue, that's just trying to get that treatment that a patient needs or that referral then that a patient needs. I've known doctors who have stayed hours and hours after their shift, and they spent, an hour on the phone without prior authorization, or, they're spending all this extra time for their patients. That's kind of behind the scenes. So the part that really gets to me is to kind of suddenly go, well, you can't trust doctors. They're kind of out to get you. And I would say is, as a physician, I can speak for myself. I can speak for the people I've worked with. We definitely are interested in not only the good of our particular patients, but in seeing people thrive, as complete human beings and live healthy and more healthy and more productive is the wrong word, healthy and more joyful lives that are free of pain and suffering. And so if your narrative that you're believing that's posted on Facebook means that we're ignoring that overarching goal that we kind of share as healthcare workers, then I would be really, really suspicious of that narrative. And that's the place that I would start from.
Well, I just want to say thank you so much. I think that's a great piece of advice. And I mean, like I said, I think you should definitely, trust in trusting your physician is, we have a great pediatrician. My primary care doctor is out of the same place, and we love everybody there. And it just makes it, so much. It makes it such a more enjoyable experience because, you feel like they know you, they want the best for you. And I think you're right. If you don't have something like that, look for another doctor till you find it. Maybe move to Waco and and go see Dr. Webb. I wanted to thank you so much for coming on. I know, you're going. I mean, just being a physician, I know that right now your life is probably a lot busier, and there's probably a lot more ups and downs than it has been maybe this time last year. So sure. I thank you so much for carving out the time and coming to hang out, and hopefully people listen to this and they'll read the blog and maybe feel a little inspired, or maybe if you're someone who kind of has been leaning into those conspiracy theories, I just urge you, please take a look, read it. It's always good to know what's on the other side of the coin. That's tjwebbmd.com. Will you stick around for me for just a minute after we wrap up?
Sure. And the last thing I wanted to say, John,
sure.
Besides just saying thank you so much for reaching out to me, for reading the blog, for inviting me to come on the show and giving me the opportunity to kind of not just talk about medical misinformation, but share a little bit from my heart as well, is I just wanted to point out to people that it is a play on WebMD. WebMD, the website that tells you have cancer. So I've had some people kind of say like, oh, so you just named the website after yourself, and clearly did not get the joke. I'm not just a narcissist that put my name up as the website. I'm really trying to kind of make a pun or a joke about, webmd.com. So just wanted to make sure to be explicit about that. Oh
yeah. And I will tell you, like, it is, I am one of those people where if I experience something, the first thing that I do is go to WebMD and I'm like, what's wrong? Oh, I have cancer. I'm dying. So that's just
like Oscar from The Office. Yeah.
Oh, I don't know if you know, there's a Pam over there and Dwight over there. We're
that's awesome.
Got a Michael Scott up there. We're an office household. So
that's fantastic.
But yeah, it's nice to have a WebMD to go to that is, number one, informative. Number two, the articles are funny, man. Like I said, you definitely hear your voice coming through, and they're not like, National Lampoon over the top funny, but like you can tell that they're written by a person with a sense of humor. It makes it enjoyable. And again, like there's legit information there that I don't know what it is about this time in life, but it's like hard to find. It's hard to find facts that are facts and not a distorted view. So I appreciate everything that you're doing. Again, I really urge everybody to check it out. And again, just thank you so much for being here. I really, really do appreciate it. Would you, I know you're gonna stick around for me, but if you are ever working on anything in the future, we'd always love to have you back. And again, just wanted to say thank you so much for being here. I really do appreciate it.
Awesome. Thank you, John.
No problem, guys. That is episode 30. Big thank you to Dr. TJ Webb. Check out the blog, tjwebbmd.com. We'll put it in the links. We will see you guys next week for episode 31.